And now I would invite Dr. Mustafa Itani, who is a dear colleague and friend. He will tackle the management of high altitude disorder. Dr. Itani is currently the head of Pulmonary and Critical Care Division at Rafiq Hariri University Hospital. He's American Board of Critical Care Medicine and Pulmonary Medicine, and he has also a teaching post in the Lebanese University School of Medicine Division. Dr. Itani.
Okay, thank you, Mirna. From the talks that preceded, I think there is very little for me to say about management. It's tackled a lot from the previous speaker. But what I would have addressed and stress from my talk, since there will be some overlap, is I'm trying to organize from the thoughts that you heard, from the management tips that you heard, and trying to put it in like an organized way, like a roadmap or similar to a guideline. So if any physician like me who is not experienced in going up a mountain and somebody come to me for a consultation, what should I tell him? So I will try to stress these points. First, the stresses that you see in high altitudes are mainly related to cold, low humidity, increased ultraviolet radiation, and decreased air pressure. However, hypoxia, as mentioned earlier, is the largest concern. And if you do go to altitudes of 3,000 meters, like Al-Qarna Sauda in Lebanon, your PO2 could be as low as 69%. So this has to be appreciated. So people who have problems or hypoxic at sea level, they should be aware that they will be severely hypoxic when they go up to like 3,000 meters. The degree of hypoxia stress depends on the altitude, but also it depends on the rate of ascent. So if you don't give your time for acclimatization, it will be a problem. And also for the duration of exposure. Sleeping is the main problem. Sleeping at high altitude produces the most hypoxia. And I will just talk a little bit more physiology here, since the issue was tackled before. What we call periodic is breathing. Periodic breathing, if you want to go to the pathophysiology, how it affects these people here, we have the hypoxia detection in the carotid bodies, the glomus cells. They detect hypoxia and send afferent impulses to the brain. So when they have hypoxia, they will send impulses and the patients will have hyperventilation and stuff like this. The center in the brain, we have 3 centers, one in the medulla and 2 in the bones. Those in the bones are related for the amplitude and rate of breathing, if you want to increase the rate or decrease it. And they are affected by acidosis or pH. So when the guy hyperventilate, what happens is his PCO2 goes down and his pH goes up, so they become alkalotic. And this will send an impulse to the brain, and the brain will inhibit ventilation, and the guy goes back to like apnea kind of thing. So his ventilation rate drops. When the ventilation rate drops, the PCO2 rise again, pH drops, then there will be stimulation for the hypoxia centers and the glomus, and then the patient will breathe again and hyperventilate. So this is called periodic breathing. And it exacerbated or happened mainly during sleep. So when the patient sleep at high altitude, you have hypoxia that goes in and out. So this is the most dangerous situation. When the patient is awake, he could control that. So it's not a big issue when the patient is awake. So day trips to high altitude with return to low altitude are much less stressful on the body because of this thing. Typical high altitude destinations that are alluded to. In Lebanon, the highest, as they mentioned, is Qarna Sauda at 3,088 meters. So at that level, we don't have much of problems. more resorts that they go or trips, like in the Peru, 3,300, in La Paz in Bolivia, 3,600. So these kind of similar things that we're talking about earlier. The Mount Everest, this is the famous one, 5,400. And really when you go to these places, then the main problems start to go up. And like Kilimanjaro in Africa, Tanzania, 5,800. So acclimatization. Acclimatization is the most important thing, okay? With acclimatization, what happens is you are giving time for the body to adjust to these hypoxia issues. When the kidneys start to compensate, you have loss of bicarb, the body become less alkalotic, so they will tend up like hyperventilate better. And this usually takes 2 to 3 days, even 4 days, until they kind of hyperventilate. And if you go to the sensory chemoreceptors, when you go for hypoxia for some time, your sensitivity to PCO2, increased PCO2 will go up and you will ventilate better. So you will maintain a low PCO2 and a better PO2 with time, and this is what we call acclimatization. And this is acute. We're not talking about the chronic acclimatization like increasing the RBCs and stuff like that, or the pulmonary hypertension related to chronic acclimatization or chronic inhabiting high altitudes chronically. And with that, we improve sleep, we prevent high altitude illness, we increase comfort and well-being of these people. However, still our exercise performance will always be reduced because you are using more of your reserve, your lung reserve, because you are hyperventilating. So you are hyperventilating at a hypoxic level, so your exercise performance will be problematic. So from what I mentioned, increase in ventilation is the most important factor in acclimatization acutely. Now, tips that you have to use when you are planning to get to any mountain. You have to look at these tips carefully and try to put a scheme or like a plan of how to go to that mountain or how to reach the top of that mountain without having problems. And this was mentioned, but I'll put it like as a summary. You ascend gradually up to 2,750 meters. And this will be your sleeping altitude. You could go beyond that, but when you want to sleep, you go back to 2,750 meter or 800 meter, and this will be in 1 or 2 days. You have to plan it 1 or 2 days. So the more you take your time, the better. Don't move your sleeping altitude not higher than 500. Some people would say, will say 300. But 300 to 500 will be adequate per day. If you plan an extra day for acclimatization, you make it every 1,000 meter, or like if you are planning 300 elevations, you could do it after the 3rd day, or after the 2nd day if you are doing 500 elevations. And this is crucial to complete your process of acclimatization. Now, if you have abrupt ascent and it's unavoidable, it's better to consider acetazolamide. And as mentioned, it should be used the day before, so it fastens your acclimatization process. As mentioned, avoid alcohol or any respiratory depressants within the first 48 hours till after you are acclimatized. Also, you have to participate in mild activities. You shouldn't exert yourself for the initial 48 hours. Have high altitude exposure before or ahead of time, like you could make 2,750 and stay there for 2 nights within 30 days if you are like planning to go to Kilimanjaro. So you could do it here. For example, you're planning a trip to Kilimanjaro. stay like 2 nights, 1 or 2 weeks before in a high mountain. You could start acclimatization process there, and you test your ability to withstand high altitude, and then you could go there and have your trip. People with no prior history of altitude illness and ascending to less than 2,800 have low risks for acute mountain sickness. So if you want to categorize your patients, you could look into this kind of profile. If you have this here, and if you advise that people taking more than 2 days to arrive at 2,000 to 3,000 meter, if you take more than 2 days and you have increases in sleeping elevations that are less than 500 per day, and you take an extra day for acclimatization every 1,000 meter, you are in a low risk for acute mountain sickness here. And really rarely you should have this kind of problem. And for these people, we usually don't advise acetazolamide or any kind of prevention. They could be there by themselves. For moderate risk patients or people, if there is a history of acute mountain sickness and you are ascending to 2,500 or 2,800 in 1 day, so there is a prior history, or there is no history, but you are ascending to more than 2,800 in 1 day, so this is a little bit more risk. And if you have people ascending more than 500 meters per day, and this is kind of your sleeping elevation, and you have altitudes, these like altitudes more than 3,000, but with an extra day for acclimatization every 1,000 meters. So the thing is, these people will have a moderate risk for acute mountain sickness, and some people would advise starting then on a preventive therapy. Acetazolamide will be much better than dexamethasone for prevention. So you could start it the day earlier, and the dose was given before. Now the high risk group are those who have a history of acute mountain sickness and ascending to more than 3,000 or 2,800 in 1 day. Or they have a history of HAPE or HACE. So these are also problematic patients. All people ascending to more than 3,500 meters in 1 day, they are at high risk. So they didn't take rest here. Or people ascending more than 500 meters per day, increase in sleeping elevation more than 3,000 meters, okay? Without extra days for acclimatization, they are at high risk. So these will be considered rapid ascents. An example of rapid ascents, if you are planning to go like Kilimanjaro, and you do that by 7 days, this is very high risk. So invariably you will have problems. So if you are planning to go Kilimanjaro and you would apply these rules, you could know how many days and what are your stops and at what level you have to plan ahead of time. So prevention is easy, and this was also mentioned before. You have to know that your early symptoms of altitude illness, what they look like, and you should acknowledge them, and you should not hide. You should not hide. You should just say that there is mountain sickness, and you should respect that you could get sicker and you could get a problem. Never ascend to a sleep at higher altitude when you are experiencing these symptoms, because they could get worse, they could kill you. So if you have symptoms, stay there till they are abated. And if you're staying there, waiting for the acclimatization to happen, and the symptoms become worse, this is a bad thing. You have to descend. It's not good. So the best scenario here is you have to descend and go to a lower altitude and try to get your acclimatization there. Acute mountain sickness usually happen in 25% of visitors that sleep above 2,500, but it's variable, some from mild to moderate. Mainly headache that start within 2 to 12 hours. It invariably resolve 2 to 3 days, but patient with acute mountain sickness, as an alternative, they could descend to like 300 meters or more, and their symptoms will rapidly abate, and they could wait for the acclimatization there at that level. Try again. What you can do also, you could give 2 liters oxygen per minute. That will relieve the headache quickly, but usually we don't have such oxygen widely available at that, in those areas. But this would help if it's there. You can safely remain at your current altitude and wait for your acclimatization, but you could treat your symptoms with analgesics and antiemetic. Don't use anything like opiates, like decreasing or respiratory depression medication, anxiolytics and stuff like that, benzodiazepines. All these could worsen your problems, make your periodic breathing worse, could go into problems. You may take acetazolamine, which speeds the acclimatization and effectively treats acute mountain sickness. Usually we use acetazolamide for prevention, and for treatment we would like to use dexamethasone. It's better for treatment. Dexamethasone is not good for prophylaxis, but it can be used. The problem is with dexamethasone, if you stop it, you could have a rebound effect. So if you want to have a better acclimatization, you have to use acetazolamide. But if there is a problem, like patients who like diabetic or have problem, and he could go to DKA and cannot use acetazolamine, it will be a problem there. So we could use other effective measures there. So it's more, dexamethasone is more effective, as we said, at rapidly relieving the symptoms of moderate to severe AMS. Now, the bottom line here, if the symptoms are getting worse while the traveler is resting at the same altitude, he or she must immediately descend. So this is a rule, should be followed. For haze usually require immediate descent. And if the patient develop ataxia of gait, usually the person, if he fails to descend, usually they have some very poor outcome. So immediately when there is symptoms that progress to ataxia, the patient should descend. Meantime, you could give oxygen and dexamethasone and try, as mentioned, the portable hyperbaric oxygen. I discussed it earlier this morning, the hyperbaric oxygen treatment, so I will not go to that here. High altitude pulmonary edema, it could occur in 1% at 1% incident if you are climbing more than 4,000 to 4,270 meters. Levels below that, usually you may not get this problem. So initial symptoms that was discussed before, oxygen and descent is life-saving. So you should give oxygen here and plan for immediate descent. You could use other medication I will go to later. And usually if you have HAPE, the progression could be more fatal than if you have haze. So HAPE, because it affects your breathing, and this is more deleterious. We use nifedipine because there is lots of data on nifedipine, and it's not because this is the best agent, but we don't have much studies on other agents. So nifedipine could be used, and it should not be used and just wait there. It should use as adjunct to descent and oxygen or portable hyperbaric therapy. So this is adjunct therapy, and the more definitive thing will be to descend. Phosphodiesterase inhibitors may be used if nifedipine is not available, or if nifedipine cause side effect like hypotension, stuff like that. And usually we don't use multiple pulmonary vasodilator. If you are using nifedipine, don't use it. If you are not using nifedipine, you could use it. So don't mix up many stuff. It's not recommended. Phosphodiesterase 5 inhibitors could selectively lower the pulmonary artery pressure with less effect on systemic blood pressure. So if you have a problem with nifedipine, with hypotension, you could go to sildenafil or tadalafil tadalafil. So tadalafil, the studies are made on tadalafil that could prevent HAPE, and this is a good study. This is a study was published in 2006 in the American Annals of Internal Medicine. So this is a good study. And sildenafil, because it has similar action, was just tried because of similar molecule and similar action. So, but the dose is different. You could use sildenafil as 50 milligram 3 times a day. And this could be also preventing HAPE. As far as treatment is concerned, treatment, we don't have much data on treating HAPE with sildenafil or tadalafil, but there is some trials and they could say that it is good in treatment. Salmeterol, it's a beta agonist, and we have this article in New England Journal of Medicine that, so it's the recently decent article, so it's supporting salmeterol for the prevention of high altitude pulmonary edema. But the issue here, it's not to be used as the sole agent. You have to use it with other, like with nifedipine if you are treating, or with other agents like dexamethasone or acetazolamide if you're planning for prevention. And also there's another article which I found published in 2007, and this is high altitude medical biology. It was done in Nepal, and it has a role in treatment of high altitude pulmonary edema. So the bottom line, use it as adjunct to nifedipine or other medication, so it's not to be used by itself. Chinese medicine, there is a tree, an ancient tree in China, and they extract from their leaf a medicine called ginkgo biloba. And it could be used as 100 to 120 milligram twice a day, and was shown to reduce acute mountain sickness in adults in some trials. And these are the trials that are published for its use. And this was as early as 1996, and then one study came in 2002. I looked into what is ginkgo biloba. It's kind of herbal extracts. The problem is it has a wide range of use, and none is like a direct medication. It's like help in this, help in that, even help in sexual dysfunction, in depression, lots of things, cardiovascular, pulmonary edema, stuff like that. So it helps a lot, but there's no definitive kind of pharmacotherapeutic indication that is clear for that. Subsequent trials with that failed to show that it is effective. And because of the 3-4 trials after that failed to show its effectiveness, we don't usually recommend ginkgo biloba because there is no data. The data are not sufficient to support its use at high altitude. So this is for the drug. This is the tree that I was talking about, and this is thank you in Chinese.
Thank you, Mustafa. It was very interesting and setting, as you called it, a roadmap, a practical wrap-up for what we learned in this very interesting original session. Any question? Yes? We'll start by Dr. Abi Saleh.
Thank you, Mustafa. It was very clear. You know, I've been hearing the 3 sessions discussing all, how acute mountain sickness and happen. Can't stop myself from thinking that, I've had trips to the Alps and I was skiing at 3,700 meters for days with my kids and with thousands of people around me. I didn't see them complaining of headaches or having problems, although they were exercising at high altitudes. How could you explain that? I'm baffled.
How long it takes you to go there?
Immediately. We just drive up there.
Same day?
Yes.
So you will have, invariably you will have symptoms, but it could be denied by the excitement. So this is what it is, because this is physiologic. This is physiology. I mean, we are not talking about like a trial or something. This is physiology. 25% of people would have some sort of mountain sickness, but it may not be clinical. I mean, it could be subclinical, like headache or some neurologic, yeah.
Dr. Deep, do you have any comment to add?
Yeah, I just read the incidence rate of acute mountain sickness in Vail Resort in Colorado, which is about 3,200 meters. I think it's about 8 to 12%, depending on where the skiers are coming from. So, number one, you have the susceptibility. Maybe you're not susceptible to acute mountain sickness, you know, like skiing, and you're lucky for that. And then you have to see like who's around you. Are they coming from the same area, or have they been there for a while? But yeah, that's very interesting. Maybe the excitement and the fresh air is basically making you forget the headache, or you're putting the headache on the account of the bottle of wine you had the last night. So I don't know.
Okay.
But about 12% is.
Okay. Any other question? Yes, Dr. Aoun.
I attend this session because I'm very away from high altitude. My question is, what is the physiopathology of pulmonary edema in this context, and why we have to treat pulmonary hypertension to treat this edema? I didn't get it well.
Why we? Sorry.
Have to treat pulmonary hypertension to treat
Yes.
pulmonary edema.
You know, the hypoxic response, the response to hypoxia, you will have severe pulmonary vasoconstriction. When you have pulmonary vasoconstriction, some say the increase in hydrostatic pressure there could predispose to pulmonary edema with the cheering forces, possible capillary leak problems, stuff like that. So this will come up to the, because it is affecting all the lung, you will have the pulmonary edema. And when you relieve the pressure, you relieve the hydrostatic pressure, this could come down.
Anything to add?
Yeah.
Please.
From what I read, I mean, it's not a very well-known pathophysiology. It's not very well studied. But the vasoconstriction is not, in the pulmonary system, is not basically uniform across the whole vasculature. So some areas are hypoperfused because of the vasoconstriction, while others are really hyperperfused because of that increased heart rate, increased sympathetic tone. And these areas which are very well perfused, are overly perfused, start leaking. Along with some production of endothelin and endothelin, which will basically injure the capillary walls. So when you vasodilate, I think we vasodilate things to take the blood away from the area that are basically overloaded. I have a question.
Yes, please.
Do you know what happened to the systemic blood pressure when you go up in high altitude? Does it go up or go down? I could never find an answer to that.
Usually, as a response to hypoxia, the peripheral vascular resistance, usually the patient vasodilate. So this is a physiologic response to hypoxia.
So, so if somebody has, for example, high blood pressure, and he's on a high blood pressure medication, he should take it or he should not take it?
No, he should be taking his blood pressure medication.
Okay. So
But the problem is there is concomitant factors here. You could have increased, if you stay there, you could have increased adrenergic response.
right.
And these people might also develop systemic higher blood pressure, higher heart rate. So it depends. I think it depends on the patient and how.
Yeah, I've been trying to avoid taking the blood pressure, the cuff with me, but I can't. I guess I have to.
Yeah, but hypoxia per se, physiologically, it will cause vasodilatation systemically, and it will cause vasoconstriction at the pulmonary level.
Okay, thank you.
Yes, but correct me if I'm wrong. We've been told by common sense, popular common sense, that hypertension is worsened in altitude, even though it's not very high altitude. Is it correct?
I don't know.
From where do we have this, popular
I think
thinking?
from the high adrenergic, from the high sympathetic activity that comes up with the high
The
altitude.
initial problem was headache, the neurologic manifestation. This could also predispose to stress. The stress, the cold, all
And
these things
hypertension.
could cause precipitate.
Dr. Itani, thank you very much. Thanks to all the speakers, and thanks you for the attendance. because you managed to counteract the competition next door of the pulmonary hypertension session. Thank you very much.